afternoon, good evening, everyone. Thanks for joining for our complex lower extremity trauma session number 2. Today's topic is on distal femur fractures. We're so excited for everybody to join us. We have an awesome set of faculty members and case presenters today, so we're excited to get started. Like I mentioned, this is the second session of our CLET conference. Our final session is going to be an expert webinar next weekend with Dr. Samuel Hailu and Pierre Marie Woolley on operating without fluoroscopy. That's going to be a new sort of session format that we're trying. So we hope that everybody can join us for a great discussion with them. I'm sure we're all very familiar with Zoom now, but just some quick tips for those of us who are here. You should be able to turn on closed captioning in your language of choice. And throughout the conversation, feel free to ask any questions or make any comments in the chat. And particularly when it's time for discussion, you can always use the raise hand function. And Dr. Jella, who's our moderator today, will do her best to try to get to as many questions and comments as possible. We have now launched SONA Global Academy 2.0. So our website has a little bit of a different look. You should be able to access all of our course curriculum on there. It is completely free to sign up and make an account. Our curriculum includes a whole host of pre-recorded lectures in English, Spanish, and French, as well as articles and essential reading, particularly from our partners at OTA. Before each session, please complete the pre-session survey, which I have also shared the link to in our chat. Our course objectives are to improve participants' knowledge of lower extremity trauma management, to foster international discussion and provide practical advice to surgeons practicing in resource-limited settings, and also to motivate and support the younger generation of surgeons globally. Our course chair is Dr. Kiran Agarwal-Harding at the IDMC. He's also the director of the Harvard Global Orthopedics Collaborative. And our course moderators are Dr. Jella and Dr. Daniel, if she's able to join. Just wanted to give a quick shout out to the HGOC and SONA Global organizing team for all of the logistics of putting this event together. And I'll hand it over to Dr. Jella to introduce our presenters and our faculty members.
Thanks so much, Samantha. That was great. I think the SONA Global Academy website is really cool, and all of the discussions from here are posted on there in addition to the whole curriculum that was mentioned. So take some time to review that, and I think it gives you a sense of what we're trying to do here. So that's great. We have some great cases to you and for you today, and some great presenters with a full breadth of experience in these fractures, and it should lead to some great discussion. Well, I'll introduce each of the presenters as we go and as they're presenting their cases, but we'll get started with Dr. Dwayne Anderson from Ethiopia, who has 2 cases to present. Just for logistics, we'll have the presenters go through all of their slides, and feel free to submit questions in the chat as we go. I'll try to pick a few of those questions to get the discussion started, and then get our faculty panel involved as well. We have Dr. Ken Rodriguez from Boston, Dr. Mike Hadid from Virginia. We also have Dr. Wigstead and Dr. Ibrahim from Beth Israel Deaconess Center in Boston joining as well. Is Dr. Fidel on the call too? If he joins, that'd be great.
Yes, he's on the call too.
Okay, great. Welcome. So outside of the faculty presenter comments, if you guys don't have more things to ask that weren't on the chat, just use the raise your hand function and we'll get you involved in the discussion as well. If there are no questions about the agenda or the logistics, we'll just get started to give the presenters some extra time. All right, should we start with Dr. Anderson's slides?
See, share my screen. Can you see my screen?
Yes.
All right, I'm going to be presenting two cases. One is, they're actually both closed fractures. One is a delayed presentation, in other words, came late and came with a DVT, which was treated, and then a delayed operation of a complex distal femur fracture. The second one is a closed fracture that presented acutely, but was not managed well in our own institution and ultimately had a second surgery to salvage her malunion. So with that being said, here's the first case. I want to give credit to my partner, Tadessa Zayas, who's now the head of orthopedics at Soto Christian Hospital. I'm just an instructor now. Okay. 48-year-old male presented with a closed fracture of his distal femur. The DVT was diagnosed and treated, and surgery was delayed. Here's his initial CT scans. You see it's a coronal shear and very comminuted bicondylar fracture with separate fragments. Here's the axial CTs. You can see it involves the patellofemoral joint, goes right through the condyles. More x-rays. Here's our setup. We have a new OR now, but this is typically the way that we handle these fractures with prepping the patient, putting in the spinal. We keep them in traction, wash them with this pan that we made on site, and prep and drape, switch to a sterile rope. And this surgery was done by Tadessa. An anterior incision was made. Excision of scar tissue, mobilization of fragments without disruption of the ligamentous attachments and soft tissue blood supply. And as you can see, inoperative traction through the tibia. Provisional K-wire fixation, lateral plating, and mobilization of the patellofemoral joint. So this surgery was done 6 weeks, at least 6 weeks after the injury. You use traction and the ligaments as aids, and sometimes they're working with you and sometimes they're working against you, but avoid cutting ligaments. Mobilize the scar tissue within the fracture. If the medial side is short, have your assistant put the leg in valgus. Conversely, if the lateral side is short, put the leg the opposite direction. In this case, both condyles are posteriorly translated and disparate, okay? I really had to work at this at times, and I've been tempted to cut the ACL or the PCL, but I don't remember ever doing it, only being tempted to do it. And here's Dr. Tedessa's final result. You can see it looks excellent. Here he is 3 weeks out. He's starting range of motion in the hospital, continuing his DVT treatment. And at 3 weeks, his range of motion is 10 to 90 degrees. Here he's at 9 weeks. Range of motion is 5 to 120. Here he's at 4 months, 10 to 120. Walking without an aid and full motion at 10 months. Here he's in the clinic. You can see the anterior approach scar and the other scars for the placement of the plate.
Thank you, Dr. Anderson. That was a really great case and a really difficult one, being intra-articular and presenting in a delayed fashion. I'll get us started with a couple of questions for me, and then we'll get the faculty panel in. You mentioned that this patient was being treated for a DVT during the treatment of this fracture. What does that look like at your institution? And in patients that have trauma like this, what prophylaxis, if any, are patients?
Okay, so for prophylaxis, we use aspirin, and I've practiced in multiple places in the world, and I think each genetic pool maybe has and this, I'm just speaking from my experience, I think has different levels of risk for DVT. The Ethiopian population as a whole has a low risk. They have a much higher risk, interestingly, for fat emboli syndrome. I had one death in 17 years of practicing in the United States, multiple deaths in Ethiopia for fat emboli syndrome. That being said, we use routine aspirin for prophylaxis. For treatment, we use the standard protocol that I think we use throughout the world, which is IV heparin, followed by or other injectables, followed by I'm blanking, warfarin, and then follow that with INRs and treat them for as long as you need to fully resolve it. We don't see people like this very commonly, but it does happen. And I think you have to weigh the risk benefits of waiting for surgery. I think the difficult things come when you have a complex acetabulum or a hip fracture that is more time. You feel more urgency to do it. In this case, we treated him for a few weeks till his symptoms had largely resolved. But that's what we do. Is for most fractures, even pelvic fractures, we use aspirin.
That's good to hear. Do any of the faculty panelists want to get us started with the discussion? Maybe Dr. Rodriguez. Are you still here, Kara?
Thank you, Sravia. No, I was going to ask, when you say it was a late presentation, was it late because the patient showed up late to first care, or was it
Yes,
late because
6 weeks late. This is not uncommon in Ethiopia. You know, if it's a closed fracture, they're less likely to come to the hospital. Many of these people go see a local bone setter and they say, yeah, we just need a little splint. So many of these patients come in bamboo splints, or they just in laying in bed. If it's not open, they do not see an urgency in it. And that's just the way the culture has been for thousands of years. Even though there's X-ray machines in every city, people stay at home.
No, yes, thank you for clarifying. I was also asking if there was a delay between the presentation and the operation for the
Yes.
management of the DVT.
Yes. Yeah. We
And
manage the DVT first.
so that's what I was going to bring up to the panel, because the pros and cons of operating with a DVT, acutely diagnosed. We often do, actually. You know, we will start the heparin a couple of days, then suspend the heparin, do the operation, and start him on the heparin again the next day. So we have not, in our protocols, we have not waited to treat the DVT to some degree before we do the surgery. So I guess it could, if it's a very extensive DVT and we are concerned of an extremely high risk of pulmonary emboli just from manipulating the limb, we may consider doing a filter. We have access to that here. So I was going to ask the panel if anyone delays a fracture repair for a DVT, is that part of your practice or not?
We
Dr.
don't
Hadid?
typically do that, I guess, at the University of Virginia. So we would do what you suggest. So we typically place a filter and then try to get to the fracture as quickly as we can.
Dr. Fadel, go ahead. I believe you're muted still.
It is a very interesting case, especially for the side talking discussion about out of the fracture itself. So the DVT is a problem, as mentioned by our colleague. The question or the declaration of doing vena cava mesh or something like to safeguard of pulmonary embolism, something like this. I think you are relying on an ultrasound or maybe some sophisticated investigation. Do you have in your, I think, limited resources, something to detect the extent of the plaque or of the DVT to do this vena cava, or how do you judge this? Or you are obliged, as sometimes this happened in many instances in such our cases in our area. Do you rely on some investigation or a man of radiologist or ultrasound, a very keen one, to give you that this is a serious and you are in need for safeguard of the pulmonary embolism? Do you have this, or you are obliged to do interference as our colleague says?
And I think as a follow-up to that question, when you do diagnose a DVT in a patient, do you then get a CT scan of the chest in asymptomatic patients with DVT to figure out if they already have a pulmonary embolism, or start treatment for DVT?
I think if it is treated and no plates, I'm not I have enough knowledge to say that, but I suspect that if it is not along a seromatous or along DVT insult, I think no need for any vena interference. And if it is healed well, no problem. I think we can go in and do the surgery under some restrictions. This is my idea.
I'm actually, I admit, I'm not aware of literature that has looked at operating with an acute DVT, pros and cons. Does anyone recall anything like that? And maybe we should operate on any DVT, unless of course there's some clinical evidence that we already having a PE or the patient is pulmonarily having issues. Then that's a different story. But in the presence of a DVT, by exam or by ultrasound, proven DVT, should we operate in the absence of pulmonary issues? Is there an indication? Are we obligated to wait, or can we just move forward with proper precaution and anticoagulation immediately after the surgery? I don't know the literature on that. So if anyone,
I have an anecdotal case,
yeah,
which I'm sure we all do, and that was many years ago in Ethiopia. A guy with a periarticular knee injury. I don't remember if it was plateau or distal femur, but we put up a tourniquet. When we let it down, he had a PE, and fortunately survived. So I think, and I don't remember thinking at the time that we missed a DVT or we should have done an ultrasound, but I think that you can, obviously using a tourniquet and manipulating the knee, you can cause a intraoperative event. In Ethiopia, there may be places where you can use a filter. It's not common to even talk about that in Ethiopia, although we do mention it as a possible treatment, but we've never done it. And I think that's why this forum is so great, is that each of us have different resources. And it would be nice to see a paper about this, to review this place like the
Yeah.
Mayo Clinic or the Harvard
Yeah.
or Harvard should be the leaders in this area.
Yeah, to your point, Karat, I'm not aware of any literature myself, right, about operating through a DVT. I think from our own anecdotal experience, we've done it and we've gotten away with that without, any real serious issues that I can remember. I mean, oftentimes we're consulting vascular medicine and they're making recommendations. And, if the DVT is proximal, then we're really considering a filter in that situation. And, it's perhaps a case like that where you're really at risk of provoking an event. And then to your point, Dr. Anderson, about aspirin, using aspirin for a lot of these, for prophylaxis in a lot of these settings, we actually have some literature out of the New England Journal of Medicine from a few years ago showing non-inferiority of aspirin with like Lovenox, even in the setting of pelvic fractures. So a lot of surgeons here are starting to recommend aspirin kind of ubiquitously, although even with pretty good literature, the adoption rate of that in practice hasn't been super high. And I think it's just due to concerns, for events like these and some of these higher risk injuries.
Well, I think a lot of it is cost in Ethiopia. You're always looking for something cheaper, and Levinox is going to be more expensive than aspirin. And so I think cost is an issue in most places in the world. Those with insurance, it's not. But that's the literature that we've leaned on. Unfortunately, we have adopted that, is that we use aspirin unless there's really a reason not to.
Well, the nice thing is I think we've defined a study to be done. We we can at least look retrospectively at all the fractures that we've done that have a DVT that were operated within 48 hours anyways.
Good suggestion.
Write that
I think
down.
that's a good suggestion. And I think sort of summarizing the talk on or the discussion on DVTs in the setting of fractures is a good stopping point of what Dr. Abraham brought up with aspirin being non-inferior to some of the more resource-intense medications such as Lovenox or oral anticoagulations otherwise, or oral anticoagulation medications otherwise. I would like to redirect the talk a little bit towards the fixation and the fracture work. Why don't we start with Dr. Anderson? What does the anterior approach mean, and how do you access the joint through that approach, and what fragments are you able to look at? And then we'll talk about K-wires as fixation for the articular fragments.
Well, the anterior approach allows you to separate fragments. It's probably the easiest in terms of getting full access to the patellofemoral joint and to intercondylar fractures and making sure that they're well aligned. Trying to do this from a lateral approach, I think would be very difficult, even in the acute setting, although I think it'd be possible. But this is a fracture with a lot of callus, a lot of scar. You want the best approach for fixation. As I stated earlier, Dr. Tedesca did this. There were, as you recall, there were fragments that involved the patellofemoral joint. And we do have Herbert screws. We have other forms of fixation. We have, headless screws of other types. Dr. Tedesca is not here to defend himself, but he's a great surgeon. You can't argue with the results. I mean, the articular surfaces are smooth. The patient's walking without pain, and he's got full motion. And you can argue with his fixation that it might have fallen apart. It didn't.
I mean, I think on the contrary, it's great to see that the K-wire fixation is, it works. Do we need headless compression screws? Do we need cannulated screws? Do we need the fancier fixation methods? But I think many participants are asking questions about what size wires are used, and do you see issues with wire migration and other post-op complications related to that?
I'm sure that can happen.
You can always use fully threaded K-wires. I've done that before. And then another little trick to fake the headless screw is just take your burr, and after you put your nail, you cut it you cut it down to the level of the bone, and then you burr it another millimeter or two with the burr, so the nail, I mean, the wire is completely hidden in the bone, and the thread is going to be there forever. Problem is, if you have an infection, getting it out, then you have to overcore it a little bit.
Yeah, and that's been kind of my concern with the fully threaded wires. So I'll bury wires from time to time. I haven't used it in this application specifically, but what you can do here to help prevent the wires from migrating and also, kind of facilitate retrieval if they need to come out, is you can kind of bend the proximal part into a little bit of a hairpin and then impact it in. So that way it's kind of stuck in the near cortex and it's a little bit less likely to migrate. And then if you need to retrieve it, it's right there for you to take out. So I've done that from time to time.
One last point of discussion here, and then we'll move on to the next case. But we've had some comments from participants saying role for bone graft when you're doing ORIF in a delayed fashion for distal femur fractures, and then I'll have the faculty panelists talk about just the general problems you see with non-unions in these fractures, whether or not they're delayed.
Well, as a general rule, a delayed fracture is not a non-union, it's just a delayed fracture. So I don't use non-union principles. I don't get too caught up with the bone graft. If I have a good reduction, I wouldn't consider bone graft within 6 weeks. If there's a big deficit, you can figure out whether you need some filler or not, but not really I'm not treating this as a non-union. This is just a fracture. The challenge here is not the healing. It's the fact that it's the deformity and the tightening of all the ligaments and getting the reduction. The reduction is the great challenge in these.
Did you do was this a median parapatellar arthrotomy or a lateral? Like you did a midline incision.
Medial parapatellar arthrotomy.
And then a separate lateral incision for putting the plate in.
Correct.
Because you can do just a lateral parapatellar arthrotomy if it's, we do this acutely all the time if we have a very badly comminuted distal articular block. And you can just do a lateral parapatellar arthrotomy and slide the plate up along the lateral gutter through that same incision without having to make a, separate lateral approach.
Would you do that in a neglected situation?
I mean, I don't take care of neglected situations like this, Dwayne, right? Like, so, I'm going to defer to you entirely on these things. We don't see this at 6 weeks, right? So.
Dr.
It's another level of difficulty.
Yeah. Yeah, if you're going to dual plate this, I can see that doing a median parapatellar arthrotomy would be particularly helpful. In this case, you have, relatively large pieces here. Beautiful reduction.
Yeah, Tedesca's a great surgeon.
Do you know what size K wires those are? Are those 2Os?
We have multiple sizes. I would be guessing just like you would.
Yeah, I'd be a little careful about putting anything less than a 2O in. They're fairly flexible, and they are not going to hold position here. You've got multiple wires, which is great. Divergent multiple wires will stop them from, you can skewer pieces at various angles. And these wires will definitely migrate. You'll see this from time to time. I had one of these migrate recently, halfway up the femur. So you got to be a little careful about wire migration.
We'll have Dr. Fadel make one last comment while Dr. Anderson pulls up the slides for us.
Thank you again for this fruitful discussion. I stress, especially for our, you can say, trainee, that it is by myself. I am not with leaving any wires freely, even in bone, because we find some hazards of this, and I say that it is so serious to use free wires and leave it. And if you get along the wires enough and impacted by hooking effect on the bone, maybe works well. And as soon as we feel that it works and finish its action, either intraoperative or later on, we should remove it, because and it is not strange to find migrating wires, and this area is so serious. Any migration in this by movement, by loosening of the wires, I think the wires is not hydroxyapatite coated, so maybe losing by movement even it is impacted inside. So my message, if you are okay with it, to our trainee, not to leave wires free even in a ball.
I also worry about that too, Dr. Fadil and Dwayne. Like especially, I use free wires a lot around the elbow. Always bend them over, trap them under a plate. I mean, when we do retrograde intramedullary nails and we do our distal interlocking screws, I've seen those come loose a lot, after the fracture is healed. So, I can imagine those wires migrating in the future, but you can't argue with the excellent result that Tedesse had in that case. Sorry, I just wanted to chime in since I'm back from my case. Shravi, I'll let you take over and move on.
No worries. Glad to have you back. Dwayne, do you want to pull up your second case for us and share your slides?
Can you see them?
Not yet.
Not yet. We're good now.
All right. I'm just trying to get I have a view of everybody on the side here. How do I get rid of that? All right. Can everybody see that now?
Yes.
Okay, great. So this second case is, as I said previously, is a case where we did the surgery but did it poorly. And so this is a repeat surgery after a failed ORIF from our own institution. And so this patient presented in August 2017 with this closed fracture. It was a comminuted bicondylar fracture, not dissimilar to the one that we saw, although it's not as displaced. And this one was done this way with a retrograde sine nail. As you can see, the interlocking screws, even from this just initial x-ray, look too short. This screw is right in the fracture site, and this one is really short. Now, there are some interfragmentary screws, but they're not enough. So again, the nail was inserted too far. There was medial comminution. This was doomed to failure. Even at 2 weeks, it starts collapsing. And I'm not sure why something wasn't done at this point. It would have been a lot easier. You can see even then there's an intra-articular step off and the patient's in varus. You can see the arrow here, the step off of the distal femur on the medial side. Difficult for you to see. It's easier for me with my own computer to see the large step off here on the patellar sunrise view. And 18 months later, she's healed in varus and with obvious step-offs, and she's not happy. So she's a 30-year-old with 3-compartmental knee pain. She's overweight. Her motion's limited. There's crepitation in the knee. There's a slight effusion. The knee is stable to exam, but it's subluxed posteriorly on CT. So she had another operation. You can see the CT shows that it's basically united. You can see the hardware. You can see some of the step off there, right here. Obvious collapse on this axial view. And so took her back for the same anterior medial patellar incision. You can see the step off here in the patellofemoral, or just medial to the patellofemoral joint. So we osteotomized her into three main pieces, two condyles and the shaft. So here's the intraoperative X-ray with two interfragmentary screws. The condyle reduction was very difficult because of scar and ligament shortening. And again, as I said in my previous talk, I've not had to cut any ligaments to gain reduction, but I've certainly been tempted to do so. Okay, here she is with a lateral plate, interfragmentary screws. You see we've got her leg exposed, not using a tourniquet here at all, so that we can gain access to the whole leg. And watching her limb alignment. Then she gets a medial plate for rigidity. Both of these plates are non-locking plates. None of the screws are locking. This is all done with last century hardware. Here's her motion and alignment on the table. See, she's over 90 degrees. So scar, I'm sure, was removed at the time of surgery. Done through one incision, maybe some stab wounds. 33 months after injury, 15 months after her second operation, that is her final result. No pain, straight leg, maybe 100 degrees of knee motion, and a happy patient. So this is an example of our failure and then proceeding to take the bull by the horns and doing what was necessary to make her improve.
Dwayne, can you leave your slides up just for the discussion and maybe go back to that first X-ray of the failure?
Sure.
I think that's a great place to start the discussion. Why don't we have the faculty panelists talk about initial fixation construct and hindsight is always 2020, but when you see these fractures that are interarticular, low distal femur fractures, what is going through your heads about fixation and post-op core?
Who is this question addressed to?
The faculty panelists. Maybe
Okay,
we'll
great,
start with Dr.
great.
Wickstead, and then
Okay.
we'll have you pull up. We can't see your slides still, so maybe we'll have you pull up just your first post-op slide.
Oh, I haven't shared, huh?
Yeah, I mean, that's a beautiful result. You just have to recreate the fracture, take it back down again, and start over again.
Is this the slide that you want?
Yeah, that's great.
Okay.
Can I ask what
The
the
injury, if you show the injury slide, might be more helpful.
and I just wanted to ask what the kind of the thought process was behind nailing versus plating in this scenario. Is it kind of a resource constraint, or was it kind of just surgeon decision at that time?
I was not involved in this surgery. I was disappointed to see it handled this way. I think that we all would probably either double plate this or at least use a locking plate. I probably, if I had seen this injury now, knowing what I do, I would have used a nail and a medial plate. I like that combination. In this fracture.
But your index surgery would have been midline.
Yes.
the block.
Yeah. Yeah. That's the way I like to do it.
Yep.
I'm an older surgeon, as you can see.
Well, hey, I'm right there with you, Dwayne. But we do have problems with knee stiffness, right? Like, you know, you're going to have some trouble with this. You've got up to about 90 degrees intra-op, but most people regress. You've got a beautiful result here. Don't get me wrong, but on average, I think you're going to have trouble getting knee motion back with a revision surgery like that.
We only show our failures with the ultimately good results.
Right. Right. We show our very best results, and on average, we struggle, even with surgery that's done acutely and done well and heals well. Do you do formal Judea quadriceps plasties? What's your take on dealing with postoperative knee stiffness?
Oh yeah, I think depending on the amount of stiffness and the delay and previous surgery, previous infection, I don't know how many quadriceps plasties I have, but I have PowerPoints on them, so at least it's a few.
I think the point that Dr. Ibrahim brought up about, initial fixation construct, nail versus plate is really good. I'm going to have the faculty talk a little bit more about their preferences for approaches as well as fixation constructs for these fractures. Maybe, Isaac, you can get us started.
Yeah, I mean, for something intra-articular like this, I actually have started to like more of a midline approach as well, kind of like a swashbuckler type approach, because I feel like it gives you a pretty good visualization of the joint. I think definitely in a revision situation, you're kind of obligated to go that way, to really get access to an ability to mobilize those fragments. In terms of fixation constructs, I mean, I do like nails for most supracondylar fractures, but something intra-articular like this, I'm still shying away from trying to nail for this. For me, this is going to get a plate or two plates.
I agree with
Dr.
that. I think, well, I'll start by confessing that I'm not much of a nail and plater kind of person. I'm a bit more of a plater. So it's something recorded. Yes, I would be more inclined to consider dual plating for this than a nail. I just don't think a nail adds much, to be honest. A nail will get you maybe 3 screws distally in a fragment that you're already plating. So I don't see the value for a very distal fracture, and this would be more a candidate for plating in my book. It's kind of simplistic, but I sometimes go back to the very basic principles. You have a C fracture. Okay, what can you do to make it into a lesser letter? and then what technique can you use to attach it to the shaft? And if you kind of stick with that, the instrumentation and the tools that you're gonna use kind of fall off nicely. Plating, this would be a complete plating indication for me.
Yeah, I agree. I think if in this kind of fracture, I'd lean towards plating. I'll try and do some nailing for very distal fractures, but I don't know in this case that a nail really adds too much in my hands anyway, especially if the plan going in is to do a medial plate regardless, then I don't know at that point if a nail adds much. But yeah, I think sticking with the principles is really critical. And I think it can go different ways, right? You can put the articular block back together first and then attach that to the shaft. Or if maybe the easiest move first is to go up and put that medial spike back together to the shaft and then build back to that. I think either way can be successful. But I think having a plan for what you're going to start with and going from there.
I think we could discuss the nail plate thing for a whole day in these fractures, or plate thing. Just moving on to the second part of the treatment of this patient, Dr. Anderson, if you want to advance your slides, maybe to the 18 months when you decided to intervene. I know that it's not common in places with lots of resources to see patients this late in the game with a malunion, but not impossible. What are faculty presenters' thoughts on management at this point in a 30-year-old patient?
I mean, I think what they proceeded with was great. I think that's exceedingly difficult, and seeing that in a healed position, right? You can't access that nail until you do all the osteotomies, but it's very difficult to do the osteotomies around the nail. So I'd be curious what the actual technical approach was, and if there are any pearls from that.
I think you got to get all the hardware out, and fortunately, it wasn't difficult removing it, and I think that was the easiest part of the operation. It's the osteotomies, and aligning it and getting the leg straight is the real challenge.
Did you end up shortening her, Dr. Anderson, at all to correct her alignment? It seemed that way on maybe some of the post-op or intra-op films.
This is 9 years ago.
Fair enough.
But that brings up a question I think that came up in the chat is did you bone graft? I mean, it seems to me that you were able to get the pieces together and then compress them. So probably you didn't need bone graft. Is that and I like Isaac's point actually, because I'll shorten through that combination.
Yeah, I did. Well, this was a heel fracture, and so yeah, it was stable with the fixation that I had, and as I recall, I was not tempted to bone graft it. I
It's a
felt
good
like it
point
was
though,
solved
because
with the
if you
fixation that I had.
Well, in this case too, as you say, Dwayne, you're totally healed. So what you're really doing here is intra-articular osteotomy, right? You're doing an intra-articular osteotomy, and then you're going to osteotomize in the supracondylar area. You're going to lag screw this thing back together to get the articular reduction that you're looking for, and then dual plate it. So you wouldn't really have bone loss here. So I'm not sure this would ever be a case like this one acutely, your revision surgery, that you would need bone graft because, as you say, it's completely healed, and what you're really doing is intra-articular osteotomy for correction.
Yeah.
We're seeing a lot of elderly high energy patients, and in those cases, the amount of comminution through the metaphysis makes it really difficult to attach the articular surface back to the diaphyseal shaft. And I think, for those of the participants who are seeing these higher energy, injuries where you have a great deal of metaphyseal comminution, it can be really difficult to reattach that articular surface back to the shaft in a way that you feel like you're not going to go to non-union. And we know, through the literature that 15% of these are going to go on to non-union. So I'm sort of curious as, how others in resource areas, deal with these higher energy, non-unions once they're established. They can be really challenging.
I think as faculty respond to that comment about non-unions and bone grafting after alignment correction, we'll have Dr. Selmy pull up his case so that we can keep moving along.
Thanks, Rabia. I wanted to bring up a point though, just because I see that this is a sign nail. In a lot of resource limited settings, I think we are struggling because we don't have lateral locking plates for a distal femur, which would be ideal, I think, for putting together the articular block and then putting a lateral plate. That's probably what I would have done if I'd taken care of this kind of patient in Boston. I rarely will put a medial plate, to be honest. So the thing is, putting together the articular block and then putting a sign nail, I think, is the only option for a lot of folks. And I think the way of getting away with that, perhaps, is to keep them non-weight bearing afterwards, which is not great if you're trying to put a nail. You want them to weight bear as tolerated. But when you have these like complex intra-articular fractures that you're putting together just with screws and then putting a nail to hold it all together and connect to the articular block to the shaft, I think that's really the only option for a lot of folks. And maybe that's what the surgeon was attempting in this case, Dwayne. I mean, you work in these settings all the time. I'm sure you see this sort of thing.
Yeah, I think having worked in Ethiopia for so many years, I was ordering implants, I was the guy who was even, doing inventory. And I don't think a lot of us that have only worked in very privileged settings understand the challenges that surgeons in resource limited environments face. My son works at the University of Utah, and I go there, a few times a year, and they've got a C-arm for every room. In fact, two sometimes. We're lucky to have, a couple C-arms from India that work kind of okay. And we had one C-arm that an OEC that lasted for 15 years, but it's dead. And so we've got another GE coming because we've been not happy with our Indian C-arms. But the challenges that our surgeons in the developing world face is just really, really difficult. And I was just reviewing the literature on these fractures, and unless patients are really osteoporotic, if you put double plating or lock plating versus a nail and a medial plate or a nail and a lateral plate, in healthy patients, they do similarly. And just because of the way that I did my practice early on in Ethiopia, I tried to do as much as I could with a sine nail. And I learned how to put screws around the nail and just fill the distal femur with as many screws as possible. And so whoever did this surgery was trying to emulate my previous practice. But when you see failures like this, you've got to make adjustments. You've got to read the literature and see what is the best treatment. And I think that double plating, lock plate, nail and plate constructs in healthy patients can get similar results. And I think for those that are in the developing world who love the sine nail, who know how to use it, and they have access to these simple non-locking plates, they can get great results without a locking plate. That's my opinion.
Thanks, Dr. Anderson. Dr. Salmi, are you ready to go with your case? We'll have you pull up your slides. Why don't we go to Dr. Alamayehu's case, and then we will loop back to Dr. Salmi's case then.
Mohammed, are you not able to pull up your slides?
Yes.
Yeah, Mohammed, we're waiting.
Share my slides.
We're waiting for you. Yeah.
Thanks.
Yes. Stop share, please. Hello everyone. My name is Dr. Muhammad Silmi, Kenya General Hospital, Egypt, under supervision of Dr. Muhammad Fadil, Professor Dr. Muhammad Fadil, LRS BD Program Directors. My case is open grade 3 fracture distal femur. This is my case. Male patient, 55 years old, presented to our clinic with a motor car accident with Gastello grade 3 fracture distal femur, the bone outside of skin, macerated and lacerated bone, dirty wound, neurovascular bundle intact. We do Dopplers and CBC and other investigation for the patient. This is my case here. This is plain X-ray, fracture and displacement of distal femur. As regards, there is a fracture of lateral tibial plateau, closed, but the distal femur it is open. الأوبريشن I do اللي frame. First, I do aggressive debridement and reduction of the fracture. Then اللي frame with wires. As regard tibial plateau, I do screw as hybrid fixation. Follow up after 2 weeks. This is a plain X-ray for follow up. Follow up after 2 months. Start callus formation, start union, and tibial plateau complete union. Then I do compression. Follow up 6 months later. Union of distal femur and the tibial plateau. I remove the Lazarov frame. Skin completely healed. No sign of infection. But still there is stiff knee, and advise the patient to do physiotherapy. And the patient early with bearing after operation. Yes. This is skin X-ray immediately post-operative on the arm. Lazarov frame, image of Lazarov frame. Follow up, last follow up, union, and skin is good, no sign of infection. Thank you.
Mohammed, can you go back to the initial x-rays just for the purpose of the discussion?
And what was your post-op range of motion?
Range of motion up to 45.
So quite stiff.
Any question?
Any comments from the faculty? Thanks, Dr. Wickstead.
How far post-up is he now with that pretty stiff knee?
What?
And do you think it's going to improve with just physiotherapy?
Mohammed, that was a question I think for you from Dr. Ibrahim.
Yes.
Yeah, I was just curious how far post-op is he now? Is it just a few months, and whether or not you think PT will be enough to improve his knee motion. I think 45 for a young patient is pretty limiting.
Patient early with bearing, there is union and callus formation, with no sign of infection.
Yeah, Mohammed, we're asking about the stiffness of the knee. He's how far out from surgery
Stiffness,
now? Yeah, how far out from surgery?
stiffness up to 45. We advise the patient to do physiotherapy. Well, stiffness is to the knee from start because الفريم limit range of motion.
Yeah, I guess the point I was just
and
trying to. Sorry, go. You can interrupt.
improved. The patient improved.
So how long since the surgery at this point, Mohammed?
6 months.
6 months. And still he's at 45 degrees only?
No, now 90 degree.
90 degrees. So getting better with physical therapy.
Still the patient in physiotherapy.
Okay, great.
Okay. Thanks for clarifying.
Did you say there was a vascular injury in this case, Mohammed?
Right.
Was there a vascular injury? You said it's a grade 3C?
I believe he said
don't.
the bundle was intact when he was
Ah.
presenting.
Okay. I think Dr. Fadil had helped with this case as well. Maybe Dr. Fadil has some comments.
I have a more, I guess, technical question. We don't see a lot of these frames, at least where I am now. But when do you take the K wires crossing the fracture out, and the timing of starting compression on your frame at the fracture?
Wire, I removed the wire 1 month post operative, and the patient still with bearing this, and do compression 2 months later on, do compression of the fracture by Lazarov frame after removal of key wires.
Thank you.
Can you
And at the time,
can you return for the X-ray the first one? Yes, go inside. Stay, go on, go on. Go on your comment, Mr. Talcott.
oh, I was going to ask one more question: is when you remove the
Yeah.
frame, do you stress the fracture under fluoroscopy, or it looks like maybe the medial side is still not healed? Is there concern that you should back that up with other hardware when the frame comes out? What would other faculty do here?
How Muhammad, you judge to remove the apparatus? Are you feel that everything is good? How can you judge that it is now suited to remove the apparatus?
How do you judge if it's healing, and do you back it up with other hardware like a nail or a plate?
I remove the Lazarov frame 6 months post operative.
Why you remove it? Are you sure that it is united or no?
United, there is no pain, and the patient
Yes.
can with bearing without pain.
And another thing, radiologically, how can you guess radiologically?
Radiologically, there is the united 3 cortices يعني lateral view can posterior cortex anterior and posterior cortex وان view medial cortex lateral cortex. There is 3 cortices united, and there is no pain, so I removed the frame.
So you have
And still the
judge
patient
radiologically and clinically. Okay.
and the clinic.
Return please for the cross wire and the X-ray. رجعنا للأشعة اللي فيها الكروس واير and
Maybe a question for both Mohammed and Dr. Fadil here is why not internal fixation in this case once you'd gotten the soft tissues under control? And then that would have maybe allowed better range of motion, early weight bearing, that sort of thing. Like, why not put a nail?
Why, Muhammad?
One operation yes.
Why you prefer to do Lazarov?
Because the wound is not clean wound, and the bone outside of skin, still outside of skin for 6 months, 6 hours. And I don't prefer to internal fixation for hazard of infection or other complication.
Okay. In my opinion, and in the area that Muhammad is working, we accept and prefer and push them to use Surf Saturn for how long to be sure that the soft tissue is good, and then do internal fixation. But in those area in Kenya, as you know, Kenya is the upper Egypt. كم ألف كيلو من القاهرة يا محمد؟ around
حوالي 600
around maybe
600 kilometers from Cairo.
yes, and he is in a hospital not fully equipped enough to do clear surgery or to some extent safe open reduction and deficient in such cases. We ask them to use available tools that they have, but prefer for them to use Elizarov actually. But Mohammed, as a beginner in this raw area, he do not all the work as if it is an expert because he missed some things, and we discussed this case in the program, and he knows some defects that he did. The most important thing is that he should have a construct more stronger than this. The distal ارجع لنا اللي فيها الظرف. The distal ring لا الثاني.
Well, the only
الثانية يا فندم. This distal ring, please. This distal ring should not be one level only. It should be two levels. So it is not too strong enough to give the knee the chance to early movement. This is one point. The second is that in case of intra-articular fractures, especially plateau, he should bypass the knee and apply also Elizarov in the upper end tibia. So we have a long frame from the supracondylar area up to the middle third of the leg. So he will keep extension or semi-extended and keep the intra-articular fractures that he reduced it, keep it until full healing and union. Until full healing and union, which may take around 6 weeks, he can remove the distal part of the construct, that one of the tibia, and leaves the patient to move his knee freely. So we will have no restriction of movement as he got. At that time, while he have a joint between the femur and the tibia, he have a joint between both constructs. So he can loosen this hinge every now and then, maybe at least 2 or 3 times a day, and gives the knee a chance to make flexion and extension. This is one benefit of doing intra-articular fracture in the femur, supracondylar fracture, and the tibial plateau fracture. The other thing which is also important and of benefit for his patient is to ask the patient to weight bearing in the same day of the operation. He can do weight bearing in the same day because he make a safeguard and bypass the knee in a distracted position. So the patient is safe in knee and they have, after 6 weeks, the way to make flexion and extension without difficulty of soft tissue contracture, because all these 6 weeks from the maybe second or third week, he can loosen the hinge of the knee and move flexion extension without loosening the construct at all. And also from the second day or the same day, by crutches he walk. So no need for any safeguard of DVT or something like this. Mohammed,
Thank you, Dr. Fadel.
As a beginner, did what he can.
Thank you so much. I think that's a great comment on being able to use something like this to mitigate the risk of potential infection, but also be able to give the patient range of motion and weight bearing quickly in a fracture like this. We're going to move on to the next case. Dr. Alamanyahu, do you have your slides open?
Thank you.
And good to go? Thank you very much.
Yeah.
I think as we're pulling up those slides, Jack was unmuting himself and maybe had a comment. Jack, do you want to say something as we get the next slides up?
Well, I just,
we're all concerned about infection. I think you can use these frames as a stage to an eventual ORAF. You can put a spanning frame on or an Ilizarov frame and use it for several weeks to ensure that your soft tissues are going to settle down and heal over your wounds and not be infected, and then take it off and give them a holiday, and then transition to internal fixation. I think sometimes for people who have a lot of experience, like our Egyptian colleagues here with the frames, for them to be in for 6 months is not really a problem. For many of us, that's a real problem, and the frames can be super useful in mitigating the infection, but it can also be a good tool, short-term use for transitioning to eventual ORAF.
Great point, Jack. Thanks.
You are right. You are right.
All right. Now, Husenai, please take it away.
Okay. Thank you. Thank you so much. My name is Dr. Nausan Alamayo. I'm a surgery orthopedic resident from Sodo Christian Hospital from Ethiopia. So I will have one case presentation, which is on open infected intraarticular distal femur fracture with a bone gap. So, so the patient was a 48-year-old male patient who came 13 hours from trauma, and he was a driver, and his front tire got flagged and he rolled over. So he complains left side knee injury. So he does not have any past remarkable past surgical or medical history. And on examination, primary survey was unremarkable. And on secondary survey, remarkable finding was on musculoskeletal examination. And there was a 4 centimeter distal anterior laceration, which was repaired loosely from a nearby clinic. And his left side of the knee and distal thigh was swollen. And there was clearly deformed left distal thigh, but his distal neurovasculars were intact. And this was his X-ray. A pelvic X-ray shows unremarkable finding. And on the left side of the distal knee, on the epi and on the lateral, there is distal femur fracture with intraarticular extension, both the metaphyseal and also articular comminution. And this is his CT scan showing comminution on both metaphyseal and also intraarticular sides. So we kept him in NPO for to take him VOR, and antibiotics has been started, and we took him for debridement. So I said serial debridement because I had lots of debridements after he got admitted. And on the first and also after a couple of debridements, he had minimal fixations of the articular surface only, and we put him on a distal tibia traction. And and on the intraop finding, there was a 4 centimeter distal anterior thigh laceration, which was deep, with no cross contamination initially. And there was almost near total transections of quadriceps tendon and multiple floating comminuted bone segments, which were taken out on the debridement. And there was a contused and non-contracting muscle, which was also debrided. And on the third debridement, there was a gross infection with purulent discharge and also a dead bone. So he required serials of debridements, and we took also culture for sensitivity and a gross checkup. And also the bone edges, those were dead, has been debrided, and because of the debridement, there was a bone gap, which is around 8 centimeter, which is created due to debridement. So the culture result showed gram-negative rod, which is only sensitive for Cipro and gentamicin. So we put these patients on ciprofloxacin. And after a couple of debridements and after checking WBC count, ASR, and CRP, we started the first stage vasculates with antibiotic cement on the bone gap, and we removed the distal tibia traction, and we sent the patients home with advice on knee range of motion and also to take the antibiotics. And when he came, in order to have a summary of his injury complex, he had an open comminuted supracondylar intracondylar fracture with a bone gap of 8 centimeter, and other issue is also infection with extensive muscle injury with a near total quadriceps tendon injury, and a stiff knee, which is as a complication because he was not doing any range of motion. And when he came after 2 months later, he does not have clinical signs of infection. We checked his WBC, ASR, CRP, so we admitted him for second stage masculine. So we went through the same scar, and we initially opened the membrane, and we removed the antibiotic cement spacer, and we did lateral side locking plate, and we did bone graft, iliac crest bone graft, and the knee stiffness after removing a couple of scars and also detaching the muscles from the distal femur, we were able to get a full range of motions. Maybe we were lucky since he was 2 months out. So on the follow-up, this is what his last X-ray. After 2 years, he was happy patients, ambulating without any supportive device, and the surgical wound was clear and dry, and he had a full range of motion. Neurovascular was intact. Thank you.
Thanks so much. That was a great presentation. I'm going to start you off with one question, and then we'll have the faculty chime in. When you initially see these fractures with floating pieces of bone that aren't attached to soft tissue, what is your institution's protocol, or your training on? Do you leave all those pieces in during your initial debridement and then come back later, or how many pieces do you take, and how aggressive are you about creating a defect and putting a spacer in, and when does that happen?
Yeah, in our setup, the infection rate is really high. And in these kinds of patients, every floating segments which are not attached, we'll take them out. And if it doesn't bleed, and even though it has attachments, we'll take them out. And it's better for us to deal with bone gap rather than dealing with an infection. So we'll take them out.
Your question is when I struggle with all the time strategy after 25 years of doing this. It's always, I think it depends exactly like Michelle stated just now, a little bit the setting and the concern and the degree of contamination. But assuming the fracture is clean, that the fracture is not full of dirt and sand and the horrible things, that it was a relatively clean fracture. Yeah, and let's just say it's been open for a few hours. I tend with time to have become more conservative and preserving the bone, right? Of course, if I suspect infection or necrotic, the bone, I'll take it out. But the problem is that I'm balancing the risk of leaving it versus the work it's going to take later on to restore bone mass or the defect that would happen if I were to take all those pieces out. And large pieces, they may retain some attachments. I tend to keep those in, and even large, 4 by 3 centimeter cortical fragments, I will occasionally leave there as well. And I struggle with that, but I tend to leave now more than I take if I suspect if the fracture is relatively clean, even in the context of an open fracture.
Thank you. Dr. Hadid, do you want to comment on the initial management or debridement of fractures like this?
Yeah, I mean, I think I would echo what Ken said. Think level of contamination, duration that it's been open before you get to debride it probably plays into it. I think once there's going to be a defect, and once that's established, I think making it a little bit bigger by being more aggressive would be my tendency. And so if there's going to be a defect there, I'd want to make sure that anything is cleared out that needs to be cleared out. But if you think you can avoid a significant bone grafting operation, an induced membrane situation, then I would try to do that. But yeah, I think it depends on the situation-specific variables and resources available to handle infection and clear infection or contamination. I had a question about your first stage. There's no fixation from the articular block up to the shaft. Was that patient immobilized at all? You'd mentioned sending them home and letting them do some knee range of motion. Was there any concern that there would be some issues with that?
Yeah, we only reconstruct the articular surface, and when we put the antibiotic cements, we put the antibiotic cement before it sets, and we usually had some sort of stability with when the cement stabilize and integrates with the fracture segments. That's why we haven't put any, and we were afraid to put metal zinc because he had infection prior, so uh, we are we were afraid to put another metal before clearing out and also managing the infection.
You may not need you may not need to do intra-articular support. You can use a splint or orthotics from outside.
I'm sorry, is there a comment or?
Yeah,
This is our
I
this is our standard way of dealing with fractures that present infected or become infected after their initial debridements is to do exactly what Nahu stated, and that is reconstruct the joint and at all costs prevent infection.
yeah.
And it's worked well for us. I had the great privilege of working with Ramon Castillo, and debridements were religious at Hennepin County. I mean, it was whether or not, it was every 48 to 72 hours, whether it was a weekend or at night, you were doing them. And I think that in the developing world, a periarticular infection has to be prevented at all costs. And I think that ORs are different, patients are different, setups are different, but it's devastating for poor patients to get a periarticular infection. Their lives are destroyed. And so this is the way that we've handled it. We've been happy with the results of this. And I think that the comments that have been made are very appropriate. This works for us.
Thank you, Dr. Anderson. Are you, a question from the chat here is about use of local antibiotics in settings of fracture like this, either in the form of antibiotic beads or local antibiotic powder. Do you want to comment on that? And then we'll go to Kerod for a question.
Yeah, so we have access to powder gent, and that's because, like I said previously, I've done it. It's difficult to get it. I've ordered it in bulk. We have packaged it ourselves into sterile used medicine vials so that we can take 4 grams and put it in a batch of cement. We use high dose powdered Vanco and gentamicin for these patients. And we also add powdered antibiotics on top of that, depending on the cultures. But there are very resistant bacteria that develop in a hospital when you're treating a lot of open fractures. And so, therefore, you need to be aggressive in prevention. And if you get a drug-resistant, multi-drug resistant bacteria around the knee, nobody's happy.
Thank you. Kerod.
Yes, I was going to ask panel's impression about the size of the defect influencing your maculae versus moving on to a bone transfer thing. I think this case is great for the maculae technique because it's mostly a medial deficit, right? You still have, if you look at your middle picture in the screen now, you have almost, it's broken obviously, but you have a significant part of your lateral cortex still intact. So you can, I have a sense, and this is anecdotal for me, that the maculae works better when you have something you're maculating to. There's some constraint in the bone versus if your defect was complete, it's a little bit more challenging to get it to heal. So which goes back to the initial question about preserving bone or not, right? Because if you had debrided the lateral cortex, then you're going from a mostly medial defect to a complete defect, and that may change your whole approach down the line. Any thoughts from folks on that? When do you debride and give up on the medulla and move to a bone transfer versus when do you what's your size limit for this kind of approach?
Dr.
Well, I think
Abraham, do you want to comment?
Yeah, actually, I'm gonna piggyback on Karad's comment. So I think like I probably would have done exactly what they did here. If this patient presented in Boston, I'm pretty aggressive with my debridements, and I feel like if you're leaving contaminated, devitalized bone, you're asking for an infection. And I think in this location, defects that are more metaphyseal and not completely circumferential, in my experience, do very well with a emasculate. And so I would have probably done the same thing here. I probably would have internally fixed the patient from the get-go so that they can, get some knee range of motion going. But I think emasculate, whether it's, distal femur, proximal tibia, distal tibia, works pretty well. My concern is when you're, kind of more into shaft and you have a sizable defect, especially if it's, basically circumferential. I worry a little bit about the ability of emasculate to heal that defect, and I probably would probably start off with the transport in that setting. And so my question, I guess, for the presenter and for Dr. Anderson would be, if this defect or this injury is more in the central part of the femur, would you guys have treated it the same way, or would you have considered shortening or some other sort of treatment option to handle the bone defect? Yes, a comment and a question.
I don't like X-fix of the femur. I think patients, at least in Ethiopia, they look at it and say, well, I can't move my knee. And so I remember patients where I had central shaft defects. In fact, I remember her name. And we actually communicate occasionally via WhatsApp. And I operated on her 10 times for her open femur infected fracture. And at one point we had a emasculate with a short rod that extended proximally and distally so that I could chip out the cement and then pull out the rod. She went through traction, X-fix, IND, multiple bone grafts, almost lost her leg at one point due to her resistant gram-negative infection. Ultimately ended up getting a retrograde nail. Ultimately, after I think 4 years, healed her fracture. Then I did a quadriceps plasty, and she ultimately got a great result. But it was extremely difficult, extremely time consuming. Bottom line is, I hate femur X-fix. I would rather put the patient in traction. I just don't like it.
Dr. Fadel?
Maybe, maybe I have a comment for this. You are brilliant in dealing with internal fixation, but actually, I have a group of femur problems until I can say freely, honestly, that if you have infected non-femur, don't think go for Elizarov. Any resistant problem of femur, especially femur, go directly for Elizarov. This is, we will meet again for many sessions of literatures and of presentations. We will may show ourselves experience because I consider this meeting not for our trainee only, but for us, because we are working as a separate islands of experience. Maybe if any one of us look for the experience of you for internal fixation, for Dr. Ken, for other friends about their experience, may have an idea what has happened in nearby island. Actually, such cases, 8 centimeter loss and length, it is not easy to compensate it by bone graft. Even if you try to mix bone graft with bone substitute, even if you add maybe if you add fibula, you may have a good impact to have this 8 centimeter if you have 8 centimeter loss. But to compensate it by bone graft, even to have REA technique, I think it is difficult to compensate by this by muscular. Also, muscular give you at last a plate. This plate asks you to wait until healing to have a full weight bearing using Elizarov and Elizarov, not X-Fix, Elizarov wires techniques. You can walk from the same day, live your life, going for the bathroom, going out, going in. So you will go by full weight bearing from the second day of the operation. Also, you can do muscular on top of Elizarov, no problem. This gives you both benefits. And also you can go muscular and bone transport inside this tube, which is healed very well and earlier than to do bone transport only. We in some difficult cases do muscular, followed by bone transport in the area of the tube. So this, I know that you did a very nice work, especially in your hospital, and especially for internal fixation. I congratulate you. We couldn't achieve this percent of non-infected cases after these conditions. As you saw, Muhammad Selmi afraid of doing any internal fixation after open fracture because we have disasters infection than that you have. Thank you, and sorry for this long comment.
No, I think that's a great comment about how we all do the things that work where we practice, and that can be very different depending on prior experience and kind of the expertise that gets built wherever you're practicing. I think this is a good time to move on to our last case. Dr. Cyril, are you ready with your slides?
I'm ready.
Okay.
So I think it will just be a continuation of what we've been discussing right now. Okay, so I'm Dr. Cyril, an orthopedic surgeon at Tenwick Hospital in Kenya. I just want to still discuss on the state management on infected distal for a patient. So for backstory, she was a 30-year-old female who presented weeks to our facility, post an RTA. First of all, after she had the road traffic accident, presented in another facility, and then they tried to do something. So when she came to us, it was because of a surgical site infection of the distal femur fracture. Among the other injuries from what she had, she also had a distal radius fracture, a left distal hip fracture. And one of the most important things for our discussion today also had a traumatic brain injury with the reported loss of consciousness for 1 hour, which will come into us. So when she presented at our facility, just generally a BP of 109/74 with heart rate of 89, saturation at 96 in room air, a DCS of 14/15, and she was quite agitated. Needed to have some cerebral discharge from the distal femur incision. For the labs, had a white count of 12,000 with an HB of 7.9. Also important, her blood group was O negative. It was noted from X-rays. Now we'll just focus on the femur part. Noted from the X-rays that she had an implant failure, having screws which are cutting out. Looking at this set of X-rays that you can see over here. So those screws were popped, like this one screw was poking out through the incision. So when we saw her, our initial plan was, first of all, we need to transfuse, and then we need to plan for hardware removal, debridement and irrigation, spanning external fixator, take cultures, and start on empirical antibiotics. We were able to do, we were able to get like 1 unit of whole blood, And then we took her in on the next day for debridement and irrigation, placed a spanning external fixator, took cultures, started on cefazolin and gentamicin just to cover as we are waiting for the cultures to be out. So these are the immediate X-rays post the hardware removal and the debridement noted with the external fixator being in situ. So about 3 days later, culture results were out, and she had grown Klebsiella pneumonia, which was only sensitive to meropenem. It was resistant to all these other drugs that we were giving. So based on this, we elected to now change to meropenem. Our previous idea was we'll do 14 days of meropenem as we want to clear infection, and then we can do now the second stage of half fixation. But now we got into a little bit of challenge because she at this time she was still severely agitated. She had repeated attempts of removal of the external fixator, and so we were really not sure of how long can we maintain the fixator. Assessing the wound, it was basically dry. We were not having discharge, and infection was systemically controlled by noted by a decrease in terms of the white count, coming from 12,000 and to 8,000 after we started the meropenem. But we had done meropenem for a 4-day course by this time. So we felt like this is a time-sensitive risk. Prolonged temporary fixation was unsafe. So we were thinking about an early fixation. But in this setting, go in for aggressive debridement and then place an antibiotic cement spacer with meropenem. Seeing that meropenem in powdered form is heat stable, can be placed in an antibiotic spacer, and can give you like a 24-day elution. So we went in and did a thorough debridement on the 20th of August. Did a thorough debridement, removed any bone that we could visualize over there. Did an ORIF with the plate, and then we placed a meropenem loaded cement spacer. After this, we completed our 14-day IV meropenem dose, and we discharged her on 27th after confirming that the wound was dry during discharge. So her immediate post-op was that, and you can appreciate all that is where we had removed every bone that we could visualize around here and replaced it with an antibiotic spacer loaded with meropenem. And we had to really place a long plate to be able to span even the previous screws which had been inserted. Yeah. So following up in clinic in October, so we noted that the wound had healed. And when we did our labs, her white count had really come down to 5.9, ranges between 4 to 11. So basically, she was within the normal. And her CRP was also down to 5 milligrams per deciliter, with our normal being less than 10. So at this stage, we were planning of what can we do now for the second stage of construction. And since we had already started the first stage mascale, we went for the second stage. Now, because of the gap that we did have, we were thinking if we do an iliac crest bone graft alone, she had a gap of around 8 centimeters. That will not be enough unless we harvested a lot of iliac crest bone graft. So we thought about doing non-vascular fibular graft, about 7 centimeters, which has been shown that it can take well if it's about 7 centimeters, making sure that when we go in, when you're harvesting, you don't enter the periosteum of the graft that you're harvesting. So we took her in, removed the spacer. We did a combination of iliac crest bone graft and the fibular graft. It was an eventful surgery she went for. So you can appreciate that is the fibular graft and intermixed with the iliac crest bone graft. So we discharged her home. The wound was doing well. She came for a 2-week follow-up. The incision site was dry. And we at 6 weeks, we there on ambulation, still we didn't have any wound issues. And then the last time we saw her was this year on 20th of January. She was bearing, fully weight bearing on the limb, pain-free. And on X-ray, there was good graft incorporation and some color formation with good function recovery. And knee range of motion was good. And that is her latest X-ray currently. So basically, I was trying to show how stability is a powerful tool in terms of infection control, and then we tailoring timing to the patient and not only the protocol, because even though we had a protocol, we had and then culture-directed antibiotics are negotiable in setting where you can get cultures that you can give the right. Then just to show how fibula graft can give structural support and also biological incorporation, and how good outcomes can also be possible in MPI infection. So we are currently just following up to see if she'll have a hypertrophy of the fibula graft, and just to see how. Thank you.
Excellent.
It was a great case and great outcome. Congratulations. Dr. Wickstead, do you want to start us off with a comment or a question?
Yeah, I mean, these are tough cases, right? You get this infection and a big hole in the bone, and you've got to span that thing. I am wondering a little bit about your working length. You've got quite a long working length here. Did you think of putting, was that intentional? The distance between your distal fixation block and your proximal screws. That makes for, quite a bit of flexibility in there. And I'm just wondering about, putting screws closer or further away, or what your sort of thought process on that is.
I think in hindsight, we should have placed, when we went for the second stage, we should have placed a screw to hold the fibula graft. But this screw was because the whole, after debridement, we had all this gap up to around here. So the closest screw we could have placed was this first screw here.
Yeah, I'm curious too. Dwayne, would you have done a nail plate combo on this? I know you said you like nail plate combos. I kind of like nail plate combos myself. And for many non-unions, that's the first thing I'm reaching for these days. What are your sort of thoughts on that?
Depending on how long it was after the initial injury, if I felt like the condyles were well healed, I probably would have just gone with a nail plus additional screws to help hold the condyle and put in a large size nail, full length nail. That's probably what I would have done, just because that's what I've done in the past. We all learn from each other's successes and failures.
Isaac, did you have a comment?
I had actually a question, more like maybe a point of clarification. So, Cyril, I mean, this is an excellent case and clinical result. But when you guys went and did your debridement, did you guys have medial cortex kind of in that segment of bone loss that was still intact? It kind of looks that way on your final X-rays, but I think on the some of the more initial X-rays, I thought you probably had a little bit more of a critical, like near circumferential defect. If you can go back to those films. So here, yeah, I guess here's a good example. Is that medial cortex intact all the way down, and maybe you have like 2 or 3 centimeters where it's circumferential? Is that correct?
Sorry, I was mute. Yeah, that was a medial cortex, but it was only the medial cortex. We didn't have an anterior and posterior of that area. So that's why we had supplement with antibiotics.
Yeah, so I think, so for me, I think I probably would have tried to emasculate here too. And I think this kind of gets back to Dr. Rodriguez's point about, what kind of strategy you're choosing to deal with your bone defects. So I think in a situation like this, where it's mostly metaphyseal or metadiaphyseal, and you have, intact cortex kind of nearly throughout the whole thing, I think emasculate does very well. I think if you're missing that medial cortex, it's a lot more challenging of a problem to deal with. And I'm not sure emasculate may have been as successful. I don't know if Dr. Anderson or Jack have some thoughts on that, but I look at that and I'm wondering what I'm doing if that medial cortex is gone. Like, am I still trying to emasculate? What's the success rate of that?
Yeah, I mean, in general, Isaac, I know you and I look at this the same way. When I'm getting into non-union territory, like I want stability and I want a lot of it. So for me, nail plate combo give me great stability. dual plating gives me great stability. And I think you're right. The mascale in combination with the more rigid construct tends to work better. Putting a fibular strut in here adds stability, right? You've almost got like a nail plate combo, right? Because you've got axial stability from the fibula itself, which I think probably helped a great deal. And so I think for people who have access to that, but or can harvest the fibula, it's going to provide some great axial stability, and that's going to support your construct as well. So I think this is, it's helpful to do that in conjunction. I don't know if that's what you were getting at, Isaac, or not. But
No, to a degree. And I think for me, right, I think in my hands, this probably would have got a nail plate for sure. I think, we, like you were saying, we kind of addressed these with a similar thought process. I guess the caveat I'm trying to make, though, is that if that medial cortex is gone, right, I'm not sure emasculate is going to work, at least in my experience. And so I probably would be leaning more towards a transport procedure. I mean, we're a little bit more fortunate with the resources we have here, but I probably would go to a transport right off the bat rather than emasculate for this.
Well, and I think if that medial cortex is gone or you don't have good contact there, you can substitute. Just put a plate on it, right? Put a medial plate on that thing, and then all of a sudden your medial, cortex is restored to at least stability wise. So my thought would be, more rigidity than you're going to get from a single plate with a long working length. I think you probably got away with this because of the fibula strut, which is fantastic. It's a great way to augment this. It's going to give you some inherent stability from the graft itself, which is fantastic.
I was going to say, when you have these large deficits that are transitioning from the metaphyseal to the diaphyseal area, there's one advantage of the nail that no one talks about, and that's that the nail uses up space that you then don't have to fill with graft, right? So if you put in like a 12 millimeter nail in there and you're using a strut, this is a vascularized fibula graft, correct? Is it?
It's a
Non-vascularized.
non-vascularized.
Oh, non-vascularized. Okay, so if you're doing a nail and a fibular vascularized strut, that's great because the nail takes a good, 1/3 of the cross-sectional area of your bone, the deficit, and the strut and the vascularized strut, which is what I've used in the past for things like this, takes out another third. So now you've got 2/3 of the space filled in, and you can use a maculae around your graft as well to do the rest, and then you get a really nice compact fill that is actually quite stable.
Dr. Fadil, did you have a comment?
We drew ourselves for a very nice discussion. May I add some experience beginning for the last words? Your last words is that some experience about infected non-union or even osteomyelitis in children. In children, in some cases, we do muscular and we didn't finish the second stage and we didn't go for the second stage. We have the bone without any second stage. This is about experience in kids and children, osteomyelitis and post-traumatic infection. In cases of using second stage of the muscular, as our colleague used fibula, non-vascularized fibula, yes, it's okay. We use non-vascularized fibula with bone substitute if we have no enough bone, because in some cases we have both iliac wings had been taken up, even the posterior also sides of the iliac crest. In some cases, we have all these lost. All these bank had been expired. So in a case, returning for about the medial cortex or lateral cortex, in those cases of no medial or lateral cortex, even a bone defect, segmental bone defect, we apply Elizarov as a protective, or we can say what you would like it is, a life-saving in this case. And for, I think maybe not written before, maybe not recorded up to my knowledge, we did in 2 cases vascularize the femoral graft in this defect. And we didn't do any bone graft at all. And may we have time to show this case for our committee, we find that this vascularized fibula from the contralateral tibia, we have a block of bone oversize, maybe double the thickness of the femur of a man 65 years old, diabetic, heavy smoker. This is happened by vascularized fibular graft on top of muscular, without bone graft, just fibularized. This is a comment of some experience I had. Thank you.
Thank you so much. I think it is time for us to wrap up soon here. I will open it up to final faculty comments, but would like to say these have been great case presentations and a great discussion today. So thank you, everyone.
I would like to add a couple comments. Thank you for everyone's participation. I think one point that we haven't really emphasized is that, and I can't back this up with the literature, but you know, when sensitivities are taken of bacteria, they do it according to blood levels. And if you put 4 grams of gentamicin powder in masculae, you're creating a very high concentration of gentamicin. And so even though the bacteria on lab test is resistant, it may very well treat that. And that's the premise that we do. Even though that a bacteria may be resistant to gentamicin, if it's a gram-negative rod, we add the gentamicin, and usually we add the vancomycin as well, because they're both heat-stable antibiotics. My second point is, in a case like this, where you have comminution and bone loss, if you put a nail in and you add a masculae, they work together in terms of stability, as Nahu mentioned. That's the way that we usually deal with these, is a nail. If we feel like there's good distal stability in the condyles, we will put a nail, we'll augment, and then use the cement as an additional way of stabilization. We've been happy with those results. I think the important thing about this is we handle these in different ways, and we're learning from one another. Thank you.
Thank you.
All right, Samita, do you want to do the closing thoughts and wrap up with the post-survey information?
Absolutely. Thank you again to all of our amazing case presenters and faculty members for taking a chunk out of your Saturday to be here with us in community and chat about this topic. For all of our participants who are here, if you could please fill out the post-session survey. Everything is now, both pre-session surveys and post-session surveys, everything is now on SONA Global Academy, all in one place for you. And for folks who fill out all of these sessions, we'll be able to provide a certificate of participation at the end of the course. If you're not already in our WhatsApp community, please do join. We have multiple communities with multiple subgroups. The lower extremity surgery group might be of particular interest to the folks here today. And again, continue learning with us. Of course, we'll have the live session recording posted up shortly after the session concludes today. We have tons and tons of other resources from previous conferences as well, including previous live sessions for you to take a look at on your own time. And thank you all once again for joining us today. We're always looking forward to these sessions and always open to questions, comments, feedback. So thank you again, and hope you have a great rest of your Saturday. And thank you again, Dr. Jella, for moderating today.
Thank you.